Schizophrenia and Other Psychoses, Chapter 31. Schizophrenia is not a single disorder, but rather it's a group of psychoses. Schizophrenia involves most complex and frightening symptoms, where individuals may hear voices, think other people or machines are controlling them, feel bugs crawling on their bodies, or believe that other people are plotting against them. People who do not adapt as well are placed in the middle of this spectrum. These individuals function within reality, but they may have some emotional overreactions, distorted thoughts, or odd behaviors. Many of these individuals won't seek mental health services because their behaviors aren't seen as a problem. Individuals at the other end, which is the maladaptive end of the continuum, these individuals are disorganized in their thought process, their emotions, as well as their social behaviors. The signs, symptoms, and behaviors of children that have schizophrenia vary depending on the child's age, their development stage, the quality of their previous experiences, as well as their coping mechanisms. The core behavior generally indicates the child's increasing lack of contact with reality and withdrawal into their own world. An impaired ability to process visual information, regulate attention, and sort out incoming information will become evident. The child's affect will change. Impaired interpersonal relationships, language, or communications disturbances may arise. Schizophrenia involves every area of functioning. The problems with motor control, emotional control and expression, perception and understanding, logical thinking, and communicating effectively will be seen. The signs and symptoms in the adolescent may include poor hygiene and grooming, strange, vague speech, lack of interest that'll lead to social withdrawal, odd behaviors like hoarding food or talking to oneself. Their thoughts may be bizarre. They may have unusual superstitions. They may believe that one is able to read another's mind. They may have an idea that they are remotely controlled by others. Self-injury and destructive behaviors will often begin in the adolescent period. The onset of acute problems most often occurs in men in their late 20s, and women usually do not present with symptoms until their late 20s. Men will usually endure their symptoms longer than women before they seek assistance. The prognosis for individuals with schizophrenia is better if they have adaptive interpersonal relationships, school performance, and work histories that were present before the onset of symptoms. Schizophrenia is seldom diagnosed in the elderly population. Approximately 23.5% of patients with schizophrenia develop the illness after the age of 40. Many older individuals with schizophrenia become withdrawn or paranoid, and often they are frequently homeless. The acute onset of psychotic behavior in any elderly individual needs to be investigated. Older individuals that lose contact with reality, experience impaired interpersonal relationships, suddenly have difficulty communicating, or experience great emotional changes may be experiencing a physical or biochemical change in their system. Changes in electrolyte balance, reactions to medications, drug interactions, and nutritional deficiencies may all cause signs and symptoms as well as behaviors that have the appearance of being psychotic. Most acute onset psychoses in older adults are related to physical disturbances, problems, or disease processes. The demonic possession theory existed until the 19th century, when two psychiatrists began to define schizophrenic behaviors. Since the mapping of genomes or genetic patterns in human beings, studies are discovering that there are genetic influences related to schizophrenia. And this has led to the development of the genetic or hereditary model as an explanation for schizophrenia. Schizophrenia may also be seen as a character flaw in an individual, or it can be believed that it's due to environmental aspects. The most common psychotic disorder is schizophrenia. Others include brief schizotic disorder, delusional disorder, schizoaffective disorder, and psychoses related to medical conditions or drug use. There are differences between the subtypes of schizophrenia. Catatonic is categorized by a lack of or a peculiar motor movement. Disorganized is showing the most psychological disorganization and lacking a systematic set of delusions. Paranoid is characterized by delusions of persecution. Undifferentiated is actually an umbrella term for individuals that don't fit into other subtypes. Residual is a mild form that occurs after at least one schizophrenic disorder episode and does not have any prominent delusions or hallucinations. The physical appearance of a person with schizophrenia is unkempt. These individuals, they focus on the inner matter that prevents them from routinely seeking out food or shelter. Their personal hygiene is poor and their body images are distorted. Their perception is the way that they view the world, and these individuals will suffer from hallucinations. In their cognitive functioning, these individuals have problems with attention, memory, as well as use of language. Their language difficulties will involve incorrect usage or speech. The symptoms of schizophrenia must occur for at least a year before an individual is given the diagnostic label. The prodromal phase begins with withdrawal, a lack of energy, and little motivation. The pre-psychotic phase, individuals are usually quiet, passive, and obedient, and they prefer to be alone. They have few friends. In the acute phase, this varies depending on the individual, but can include disturbances in thought, perception, behavior, and emotion. These individuals frequently will lose contact with reality. For remission, it is the ability to manage some basic activities of daily living that return, but the individual still will have some distresses of psychoses. Brief psychotic disorder is a psychotic disturbance that lasts for more than one day, but less than a month. Delusional disorder is characterized by more than 1 month of non-bizarre or reality-based ideas. This individual is able to carry out activities of daily living, but still holds on to the delusion. The delusion may involve being followed, poisoned, or having their own thoughts controlled. Schizoaffective disorder is diagnosed when individuals show signs of a mood disorder as well as schizophrenia. Usually the moods of individuals with schizophrenia are flat and unreactive. Schizoaffective disorder experiences changes in mood. The disorganized behaviors of schizophrenia are still present, and the emotions may move from depression to elation. When a person is institutionalized, the goals are to help stabilize the individual, and we don't want any further decline in their functioning. The healthcare team assists the individual in coping with their issues at the moment to try to help get to an underlying cause of the disorder. Psychotherapies will include the following: a cognitive behavioral therapy that can help identify and change ineffective patterns of thinking and behavior. Cognitive enhancement therapy is to build brain capacity through the use of computer exercises and group work. It helps to organize thoughts and increase intellectual functioning. Supportive therapy helps to assist individuals learning how to live with psychoses in more healthier ways. There is also family psychoeducation and support to help teach the patients and their families how to bond, problem solve, collaborate, and then learn from each other. Interventions for individuals with psychotic disorders will include ensuring their safety and maintaining it, establishing a trusting nurse-patient relationship, confirming the patient's identity, orienting them to reality, assisting the individual in communication to help them understand as well as be understood, help the individual manage anxiety, encourage responsibility for themselves, assist with activities of daily living, promote social interaction, regulate activity levels, encouragement and praise social acceptable behaviors, and teach them how to identify stressors as well as manage, recognize, and prevent any symptoms. Signs and symptoms of tardive dyskinesia can include a protrusion of the tongue, puffing of cheeks or tongue in the cheek, grinding, chewing, lateral jaw movements, lip smacking, grimacing, tics, blinking, squinting, an impaired gag reflex, shrugging of the shoulders, thrusting of the pelvis, toe movements, foot tappings. Discharge planning needs to include medication teaching. When the individual is not taking medications correctly or not understanding the need for compliance, this can lead to the relapse of their symptoms.